think in medicine there's almost nothing else that you can do that can make such a difference so quickly to people's lives who might otherwise be struggling about as much as you can with an illness. You can turn that around really quickly, and it's very satisfying work.
And you very quickly develop some really good relationships with those patients. You get to see them on a regular basis, and you have a lot more interaction with them than you do with any other patients who are coming in getting medications once a month, for instance. So you can see the difference that it makes in people's lives because you're interacting with them so often.
Contrary to what you'd see in the media, where these people are out having a great time and enjoying what they're doing, I can assure you that's not the case. They often feel just chained and constrained, and their life has been taken over by this dependency. So what we do is we remove this craving and the wanting and the seeking of the substance.
We have a good treatment, a treatment that helps them to feel normal within a day or two, is amazing. It's, and very much appreciated by those people too.
It can be very fulfilling. You tend to have a lot more input into people's health because you're seeing people on a regular basis, and they trust you a lot.
And then you can get on and deal with perhaps some underlying problems that this cohort of people have, but also just their general medical problems.
And we expect that SafeScript we may catch up with some of those who are visiting doctors or a number of doctors to get scripts. And doing that, I've come to learn, is a survival tactic. Because some of those sort of behaviours are really about survival. Actually, my life changed radically when I realised that a lot of these behaviours are a way you survive with your dependency. But then I hope then we could offer them some treatment, end their dependence.
Patients arriving with the problem of opiate dependence are difficult to deal with if you don't have the tools.
If you create an environment where you are making it clear that you're unsure, or you have a negative attitude already, or you don't provide the same amount of time that you would for anybody else, you're going to create the situation you're worried about.
But having that toolkit there gives you confidence in being able to say, no, I'm not going to hand over something that I'm comfortable to do. But I can offer you this more appropriate treatment.
Well, what the doctor I now have did when I finally arrived at his doorstep was at me, and I told him what I wanted, my list, and he said, no, I won't do that, but I will do this. Not only did he have boundaries, he knew what to do. He knew he had to cover pain, but he knew there was addiction raging. And the first thing for him was rein it in, get control of the addiction and the opiates, that medication.
In fact, I've had a couple of cases where patients have not been ready for that, and they may have even stormed out of the room because you weren't giving them quite what they want. And a storm out of the room is, that doesn't really hurt anybody. The occasional door slamming, other than sometimes it can be a little bit upsetting. But I've found in a couple of instances, those same people coming back to see me, maybe a week, maybe a couple of months, maybe even a year later, when they realise that they need something else, that their life hasn't been going the way they would like, and they actually want to get help.
My philosophy around medication and therapy for any condition is that they should all be treated the same. Realistically, you can get a program with methadone and buprenorphine films running for less than a few $1,000s. If you have a price point for the clients, it'll run at least at break even.
And these people have a chronic illness, therefore they qualify for a GP management plan. So we tend to complete a GP management plan with people. They also generally, with having a team care arrangement prepared, because they have the GP, the pharmacist, often there might be a drug and alcohol counsellor or a psychologist who might be involved as well. So therefore there is a team immediately. So that enables the practice to be a bit financial, particularly with those early assessments. The ongoing work with people once they're stable on this treatment can be quite simple, in fact.
There's sometimes people have an image of your life's going to become taken over by treating people with substance use issues, whereas a practice like mine, I think I've got about 12, 15, somewhere around there, and I've kept it at that for years.
And I've had pharmacists who've told me that well, somebody else will fill those scripts that don't really need my service. But in this area here in North Coburg, there are over 1,000 permits in the region, so there's definitely a need.
I did a little job with another general practice, and part of the interviews, and I said I could prescribe methadone. And they said, "Oh, that's okay. We don't have anybody here who's that way inclined." And the first day that I worked there, a fella came in and was asking me for morphine, and I said, "What's going on? What are we doing here?" And he said, "I've been just getting morphine for a long time. I used to use heroin, now I just get morphine instead." I said, "Look, I can offer you something a bit better. We can stabilise this and get it sorted out." So sometimes you don't realise the need until you provide the service, if you like.